I would like that too. Open the meeting of the Health and Human Services Oversight Committee for Friday, October 27, 2023. Would the clerk please call the roll?
Representative Pearson.
Here.
Representative King here. Senator Gray. Representative Murphy. Representative McDonald. Representative Weber.
Here.
Representative Edwards.
Here.
Representative Merchant.
Here.
Senator Rosenwald. Senator Avard.
Here.
The chair received requests for absence from Rosenwald, McDonald, and Murphy. And I also did from Representative Edwards, but he decided to come anyway. I will entertain a motion to accept the previous minutes. Senator Gray.
So moved.
Second.
I'll second it, but I have a comment.
Now we may comment.
Okay. I don't know if our regular minute format handles this. Of course, I was absent last time, but it bugs me to not do my job. I was out on medical though, so if there is a way to condition the kind of absence or qualify it, I'd appreciate it.
Okay, if the clerk would add that, and I gave you those who had already called in with excused absences. Thank you. Any other discussion? Seeing none, all in favor of the minutes?
Aye.
Opposed?
Abstain. I was not here.
Same.
Okay, so you cannot find any errors in the last meeting then?
No, I cannot. Take a look.
I have no idea what the rules are on these committees, but generally speaking, House members aren't allowed to abstain from things. It may be fine, I don't know. I wasn't here either, but I'm going to vote yes because I think they're probably okay.
Okay, so if the rules allow it, Representative Merchant abstains. If they don't, he votes yes.
Just as a point, the Senate operates under Robert's rules. You guys under a different set of rules, but Robert's rules would allow you to vote in favor or against the minutes, whether you were there or not, based on your knowledge of what went on, either through, hearsay, watching a video, or whatever. So I certainly have no problem with them voting or not voting as they choose.
Mr. Chair, I because of Robert, I will vote yes.
Thank you.
As a quasi-Robert, I'll vote yes.
Okay,
I like Bob. I'll go yes too.
I was given Masons for Christmas, so I'll have to reread that section, but I think we've approved the minutes. The nomination, next item, nomination of Jay Gupta, Director of Pharmacy and Integrative Health, Harbor Care, New Hampshire, is an adjunct member to serve on the subcommittee of this group on Alzheimer's disease and other related dementias. Mr. Gupta here. Representative Merchant, would you speak to him as a fellow pharmacist?
I will. Mr. Gupta comes to us with an extensive background, both as a pharmacist as well as somebody who worked in the industry. And he also has spearheaded a lot of things at Harbor Care, dealing with pharmacy coverage and working with patients and trying to allow them to get coverage that they need drastically. So he's very versed in the issue of trying to understand the pharmacy world and trying to migrate patients from the need of drug therapy and finding ways to get that taken care of by the payers or finding sources for them to do that. I think we get into Alzheimer's, we're going to have the same issue because a lot of the drugs are expensive and a lot of the ways in which patients will access the pharmaceutical care, we've predicated upon that access point. So I therefore bring him to our committee as an adjunct to the committee, subcommittee.
Thank you. This was a subcommittee that is on in the law books, and in the 7 years I've been in the House, had not met, but people had come to me and said, would like to crank it up again, so we did. There were a few people that some of us felt should have been named as regular members, but the people who got named to their slots were equally good. So what to do? Well, they could just come. They could just show up if they wanted to. But I wanted to recognize pharmacist Gupta and also Dr. Jeffrey Soloway in this little special way. So they are not voting members, but they will be participating members to the degree the chair allows that. So that's the backstory to that. Next item, and I'm going to ask if, I think it's the chair's nomination, but if you'd like to vote. Yeah, I think so. Then we don't need a vote. But had it not been, would you have voted yes? I thought so. Next, if Attorney Edwards would explain what the next section is, please.
Williams? You said Edwards. Did you?
Williams. I said Edwards, but I meant Williams. You both knew that.
Chairman Pearson, members of the committee, we worked together for so long that I absolutely knew exactly who he was referring to. So thank you very much.
And I tried really hard not to insult you by calling you representative this time.
I don't have a response. But with that, I want to thank you for this opportunity to be a resource to the committee. Chairman Pearson, working along with the department, were able to identify legislation that passed this past session that includes items that were either for new reports or for action items for this committee. I look to Representative Edwards as the chair of Division 3, who very thoughtfully during the budget process identified certain areas where the subject matter that is germane to this committee would have some type of either a reporting item or some type of review and approval. So what you have as part of your agenda, when you see it, is a kind of a reduced down version of the number of items that were passed this session. I will say, since I've been doing this, I've never seen 4 pages worth. You do have a more annotated document that gives you the background over the types of items that have been added for this committee's review, but certainly you've met a benchmark of quite a few items that have been passed this past session. So I don't know how you would like to handle it because there's only 15 minutes to review all of the items. There were particular questions from the committee on certain items just to scan over, and certainly if I'm not able to respond, I know we do have members from the department in the audience who could also participate. But today is a review of the items that were passed. It's not the actual review themselves. Those are being calendared for review by this committee or on the agenda. There is one item I would point out that Director Wendy Altman with our long-term supports and services, the Bureau of Elderly and Adult Services, will be here today to present the plan as it relates to an awareness campaign around Alzheimer's and related dementia. And so that is one of the items on this list that is scheduled for your review today.
Some of these will naturally be showing up on our schedule, our agenda, correct?
Yes, naturally.
And since that's the case, do we simply wait for them to show up? And is what we're now doing looking for the ones that might not naturally show up to ask them to show up? Is that what you suggest?
I don't believe that's what I'm suggesting, because I think this committee has done a very good job of keeping a matrix of all of the reporting requirements. We certainly do add those. It's interesting, though, that is a good question for the chair. There is no requirement on many of the reports to actually present, but we have historically done that. And so we've had members not only from the department, but you'll also see on the list of the new requirements that there's other agencies like the, in this case, the Department of Labor has now been charged with workplace safety in clinical settings. They're added to the list. You also have the Office of Professional Licensure and Certification. I believe that there's a reporting item for them, or at least a review item for those groups.
So are you suggesting we read down the list and when we see something interesting, what?
However you'd like to handle the review.
Yes, please, suggestion. Thank you.
My suggestion would be, and thank you very much for this as a resource because it's really useful, so thanks to both of you who generated it. that perhaps we could save time by taking it away with us and coming back next month with any suggestions about action items for anything that doesn't fall into our natural rotation. But Mr. Chairman, I also wanted to express a concern because our agendas have become fuller and fuller, and fitting it all into 2 hours once a month has apparently become harder and harder. And I don't know whether we ought as a committee, and not necessarily today, to think about either setting a longer time block or meeting more often, because I'm really worried that we have a huge docket of really important things to go over, and I don't want any of them to get short shrift. So I just throw that out as a suggestion. Once we add these onto our already full docket, I'm concerned that we're going to fall farther and farther behind, or we're not going to be as thorough as we have traditionally been.
Representative Weber was one of my good mentors when I first became a committee chairman, and she's continuing to do so. So might I suggest, what do you think, Representative Edwards?
Thank you, Mr. Chair, and I endorse what Representative Weber just said. I was just going to suggest that as a rule, that since the department knows which of these areas that Oversight has some accountability for getting involved with, that a management by exception approach be initiated so that if we're out of cycle from a report and something seems to be going wrong or askew that we ought to be aware of, to go ahead and take the initiative to bring it to the committee and let us know. That would be one thing that I would want to do. And then I have a second comment, if you'll allow.
Follow up?
Okay. At this point, would it be inappropriate if I ask what I would hope to be a short answer regarding one of these items? Okay, so, Mr. Williams, HB 2 on the Healthcare Workplace Violence Prevention Program did what the commissioner had asked. We put into suspense for this budget period DHHS's obligation to basically provide some leadership and some database work and some other things. And when we did that, the intent and hope was that the private sector would stand up and make it happen without the government involved. Do you have any idea if the private sector is stepping into that vacuum?
And Chairman, if I can respond to Representative Edwards' question. Well, on your first item that you did bring up, I just wanted to respond about bringing emergent issues or bringing reports to this committee. We have historically worked very closely with this committee, and certainly those items, as matter of best practice, have been brought before the committee. So that's this first item. So great idea is something that we've already been adhering to. The next item is where we are around this very important workplace group. And I know there's members of the audience who are feeling a gravitational pull who are not necessarily with the department that work for perhaps hospitals and other associations. But you may recall, and Senator Gray, you were very much instrumental in the first bill that created the Workplace Safety Commission. And the concern that we had, and the reason why the original bill had its effective date pushed out, was to allow our agency to respond with building into the budget the necessary resources to do the data analytics that were required as part of that proposal. As the bill made its way back through the legislative process in the budget cycle, and working with Division 3 and working with you as the chair of that committee, Representative Edwards, we were able to work very collaboratively with the Department of Labor, and they were more than gracious to accept the responsibility to having the work administratively attached to them. We certainly are an important player, particularly because we do have institutions like New Hampshire Hospital, Hampstead Hospital, residential treatment facilities, and others that we certainly benefit from the work of that group and the data to keeping our staff safe, but it's now housed with the Department of Labor. So that's one of the items that I actually mentioned, that your new deliverables in terms of folks coming before you have been expanded beyond just HHS, but to other entities as well.
Okay, so as I summarize what you just said, is that DHHS has suspended their leadership of this program. It's been transferred informally over to the Department of Labor, and that makes me think that we may need a legislative tweak. And if we need a legislative tweak to pin the rose on labor, let me know, and I'll try to figure out how to do that tweak.
And Chairman, I just wanted to make sure I understood when I think I heard the word informally. If that was the word, and I apologize because it was actually formally done as part of the legislation that came out through the budget process to realign with the Department of Labor from our agency. However, notwithstanding all of that, the Commissioner, Ken Merrifield, is certainly a wonderful person to work with, very collaboratively with, and we look forward to the opportunity to continue working with him. This is an important commission for the department, and we do serve on the commission. We're active participants. The transfer, however, to the Department of Labor, because they deal with labor issues and workplace safety issues, that it was better housed with them, and we really appreciate them stepping up. I do believe, and I'd have to look back at HB2, but I do believe there were some additional resources either in HB2 or in the operating budget that was provided to support this program in the data analytics. And again, I know we have people in the audience, but with the brevity of time, I probably shouldn't be gravitationally pulling anybody up at this moment from other outside entities.
Thank you, Councillor. The chair would like to take up Representative Weber's suggestion that we look down this list and ponder it for the next month and talk in a 91A respectful manner amongst ourselves, that we could perhaps come back with a few further thoughts. Also, just before we get too far away, I want to thank Attorney Williams, because he's putting suggested limits on time, which is why we adjourned last time right at 12 o'clock with a big agenda. It's encouraging us to time discipline. And thank you for coming up.
You're quite welcome. And ironically, we are on time, even though I think my commentary went maybe a little bit too long. Thank you.
The other thing I wish to bring up before I forget it, this is triggered by the nomination of somebody to a subcommittee. I've been approached by somebody saying there's other subcommittees that are lurking in the law somewhere that come out of DHHS Oversight Committee that maybe want to be reassembled. And I'm quite open to bringing that forward to this group. Just if the one I spoke to earlier has anything further, please speak to me afterwards. Anybody else hearing this? If there are other subcommittees that should be meeting and you want to meet, just talk to me. Next page. DHHS Commissioners Update. Congratulations to my fellow. We share Milbank Fellowship in, was it Public Health? I think it is. Something like that, yeah. So my fellow, newly appointed Deputy Commissioner, congratulations. And with her, the man I affectionately call Jersey Jeff, who replaced Jersey Joe. We've got a good pipeline down there to New Jersey, and it's doing DCYF a good thing. So welcome, both of you.
Great. Thank you so much for your kind words. And the commissioner sends her regards as well, and her regrets that she's not able to be here today. Occasionally when you're have the privilege of being in a position of executive leadership, you post a job and an applicant comes along and you say, this is exactly the person we need for this role right now. And I believe that is what happened to us now 6-7 years ago when Joe Ribsome came along as DCYF director over the course of 5 years. Transforming, and I mean that cliche word with no degree of overstatement, our child welfare and juvenile justice systems. And with the announcement of Joe moving on to a different role at a national level, when I received Jeff Fleischer's resume, and I think I responded in maybe 5 minutes, which he kids me about a little bit now, it was clear that this was exactly the person to continue building on the foundation that has come before while moving us in even more positive directions for kids and families. And so at your request, wanted to give Jeff a few minutes to introduce himself, talk a little bit about his vision. I want to acknowledge traditionally, DCYF has actually reported up to Children's Oversight Commission, led by Senator Carson, and as its kind of oversight body. But part of the beauty of the direction that we've been headed with DCYF is that the entire program, the efforts that Jeff is now taking the helm of and leading, are really understood in a paradigm that is side by side with health and especially behavioral health. And so one of the best symbols of that has been Jeff at Children's Oversight, which happened last Friday, sitting side by side with Katya Fox, our director of the Division for Behavioral Health, co-presenting, co-leading so much of what needs to be integrated across the department to help families and kids get what they need. So without further ado, I want to introduce Jeff. I'll just say by way of background, he has nearly 40 years of experience leading one of the nation and really the world's most respected nonprofits, the Youth Advocacy Program, which is entirely geared around helping kids, families get the services they need, and in most cases, altogether avoid the need for acute levels of care, residential, detention, et cetera, which of course is where New Hampshire is a leader and continues to go. So with that, I want to give Jeff a chance to introduce himself, his background, and his vision, and then leave some time for your questions.
Yeah, thanks so much, Marissa. Yeah, so here you go.
That's the hardest part of the job, is making sure the light's on and, you know.
Yeah. Thank you so much. Yeah, and you couldn't have chosen a better deputy commissioner, except she was my boss, one of the best bosses I ever had, so I hope she gets replaced with someone near to her leadership skills. Yeah, just thanks for inviting me just to spend a couple of minutes with you. As Marissa said, I spent 47 years of my career running community-based nonprofits, and the last 38 specifically alternatives to youth detention, youth incarceration, residential treatment, and acute psych hospitals, developing community-based organizations and community-based plans as an alternative to those high-end at-home placements. Also did quite a bit of work in gang intervention in about 30 of our major cities across the state: Chicago, Philadelphia, Baltimore, Newark, New Jersey, where I'm from, and many others, and also many rural areas in Arizona and Alabama and upstate New York and other places. So I was very interested, and I was a big fan of Joe and the amazing array of services that were built here over the last 5 years, millions of dollars in new programs that the legislature and DHHS really developed for our high-risk kids here in the community. So my goal, my overarching goal, is to really build upon the strengths of the existing community-based system of care, and fill in the blanks, fill in the gaps, stand it up, improve upon it, and make it a national model for kids and families with the highest risk of out-of-home placement. By doing that, we have a few major goals: reduce our reliance on residential placements, maintain a low census at the YDC, redirect our funds from the residential line to our community line to continue to strengthen our community-based system of care, and achieve better outcomes for kids and families, particularly those that we've marginalized, pushed out, sent out of state, or linger in Hempstead or the SYSC. So it's really about building upon our current system that works great for 98% of the kids in our state. And I'd like to say that we're now going to build a continuum for the 2%, the few hundred kids that right now are not on a track for success. And they need some really robust interventions and really robust supports for their families, their foster families, their kinfolk, and themselves. So I'm there, and any questions?
Representative Weber.
Thank you and welcome. It was a great honor for me to be able to work with Director Ripsom for some time, when startlingly all of the people who were on the Child Abuse Fatality Commission came from Health and Human Services rather than Children and Family Law, so I had to learn a lot very quickly. I will also say that I am a CASA and work with children who are stuck in the system because of abuse and neglect issues. And the one thing, I'm sure it is no news to you, but the plea I want to make is that when we have kids and families that are intact still, that are still with their parents, and we have found a counseling resource for them, my experience is they just begin to trust a counselor and the counselor goes somewhere else and you have to start over again. And these are kids and families that are not programmed to trust anybody easily. So anything that we can do to promote stability in the system is a really good thing, and I just put that out there. And as I say, I know I'm not telling you anything you don't already know.
No, that's, thank you for that. And that's really, what you just did is hit on our main theme. A kid yesterday who's been kicked out of several residential placements in foster homes said to his worker, I have nobody. I have shift workers that come and go. I've been to, a dozen agencies, a dozen foster homes. I don't have anyone to go to. And that's exactly what we want to do, is develop a system of care where every kid in need has a go-to person. Someone who's going to be that, as you said, the continuous person in their life that they can trust, that can develop trust, that could be their advocate, could be their mentor, their broker of services, and there for them when they most need them. And I think all of us in this room, if we had any trouble when we were growing up, probably, because of where you're all sitting, we probably had someone that helped us along during very tough times in our careers and our lives. So that's it. You hit it right on the head. If we can develop those kinds of systems. There's one pilot that we're now beginning, which is a paid mentorship program. Right now it's a pilot, so it's reserved for those kids with the highest need, those kids that are lingering in our facilities, don't have any connections. We're going to hire paid mentors from the community where that kid lives. They can work 5, 10, 15, 20, 40 hours a week, face-to-face contact with a young person and their caregiver to really provide the robust services that that kid needs until they're stabilized. Then those hours can go down, and then they can go into more cruise control until a crisis hits, and then we can spike up those hours again. So we're reserving that now for the highest need kids, the ones most at risk, the kids that have nothing going for them right this moment. So again, your theme is perfect, and that's the direction we'd love to head.
Senator Gray.
This is part of preaching to the choir, but I am an engineer. I usually say I are an engineer because we're not known for our English, but you get what you measure. And the only part that I would revise in your statement is keep the number of people at YDC down, okay? And what I want is the appropriate people to have the services of YDC. You know, if that number has to go up because they need the services, that's the right thing. It's not keeping the number down that is the goal. It's the right services, which comes through in the rest of your speech. But again, I are an engineer, and I just had to say that. Thank you.
Yeah, no, got it. Yeah, we want, no kid should be there, doesn't need to be there if there are other services in the community. So that's more the way to frame it. So we want to build a front-end system, programs to prevent kids from going in that normally would have gone in, and on the back end, a robust aftercare program so they don't come back. Right now, 70% of the kids that go to YDC come back within a year. So we want to change that number. And that's why reduce our reliance on the YDC. But you're correct. The kids that need to be there, we hope to have a great trauma-informed, small facility to treat those kids.
From the chair, after the scandal with the facility in Tennessee that child advocate Cassandra Sanchez discovered, there was some quick putting together rough legislation. And would you, Deputy Commissioner, would you care to speak to the process of bringing this around to a consensus?
Yeah. So thank you, and thank you for your leadership in convening us around how to think in the in a way that's both strategic but fundamentally advances our common agenda around what kids need and the need for strong oversight, use of residential only in the right cases, and then the assurance of safety at all times. So what I can say is, as you know, we are finishing our review of your draft legislation, and thanks to the way I think that you brought us together, there's a very interdisciplinary group engaged in that, both across DHHS, as I mentioned, really strong leadership from the Division for Behavioral Health, DCYF, but also working directly with the child advocate on the 98, again, to reuse the 98% metaphor, really the vast majority of things we agree on and want to see. And then appreciate your help shepherding that through the legislative process. So a lot going on even in the last few days, and we're feeling good about and grateful for our involvement in that.
The other fellowship I hold is in child welfare. And what I discovered when our cohort last met was most states have a DCYF or the equivalent and an Office of Child Advocate. And in many states, they are highly adversarial to each other. And my goal is that we will be collaborative whenever possible, and I think it will be possible most of the time. And I wish to thank you folks at DHHS, plus the Office of Child Advocate, with agreeing with me on that. And the good news is, with the deadlines we have, I hope that by the deadline we will be able to have a revision to the bill as submitted. But if not, when it lands somewhere, and it's either going to be with you or with me next year, there can be a chance for further tweaking. So I think we're on the road to something good here, and I want to thank your cooperation very much. Anyone else? Representative Edwards.
I'm assuming you don't have any other remarks that you came ready to, okay. So in that case, I have just sort of a setup for you. In fiscal committee last week, there was a request that the department revisit Dr. Chen's letter relative to the summary of COVID research. And the reason for the revisitation was that it was the response that we got was extremely broad, and it basically was a boil the ocean kind of thing. And because I think the medical intelligence is suggesting that COVID is not gone and we're going to have to deal with it again, I would like us to get our best foot forward and be prepared to answer the question to parents of whether or not we can tell them that the clinical research demonstrates that otherwise healthy children under the age of 18 or those who have had a natural immunity are good candidates for receiving the COVID. I think you can tell my bias in my question, but I do think that DHHS should just have, even if Dr. Chen, all he did was saying, yes, I think the science demonstrates that children under the otherwise healthy children under the age of 18 ought to get the COVID shot, Ben Chen, then that would be fine. I just want us on record so that parents know what we're really telling them.
Yeah, thank you for that comment, and please know that as a department, and also, of course, our leadership, including Dr. Chen and the Division for Public Health Services, are committed to getting that communication out in the channels it needs. I know as a parent of a little one that I depend on their guidance around timing and around this other information. So appreciate it, and please know we're working on it.
Seeing no further questions, thank you so much, both of you, for coming. We'll see you soon. The chair recognizes the Honorable Kendall Snow, an alumnus of Health, Human Services, and Elderly Affairs Committee. And it is so good to see you again. And I will write that note if you need pressure, so you'll run again, please. Thank you very much, Mr. Chairman. And we got to turn the mic on until we see the... You do. You just haven't gotten there yet. I'm sorry.
And there's a handout that
There is a handout. Yes, thank you. It's called Memo.
Thank you very much, Mr. Chairman. by way of introduction, I think many of you know me, but I thought I ought to just say I was very proud.
Just a little closer to the microphone for my elderly ears, please. Thank you.
Thank you. I was very proud to serve as a representative serving on the Health, Human Services, and Elderly Affairs Committee from 2015 to 2021. And I miss it dearly. I'd sincerely like to come back if I can get the okay from various people who also have an influence over my life these days.
Excuse me, could I just get 2 more copies of your memo? Thank you.
There you go. I have plenty. I have plenty. I should also say that for 48 years, I served on the staff of the Mental Health Center of Greater Manchester as a social worker and advocate. And for the last few years, I was vice president of community relations and development at that agency. And I have a continuing interest in the mental health center and the other mental health centers in fulfilling their mission in New Hampshire. And I stay in touch regularly with the leadership team that I used to work with at the center, and at times around other staff to see what's going on so that I'm familiar with what's happening. I would like to say that I think it's without a doubt clear to everyone that the federal COVID pandemic protective emergency order that came into place in March of 2020 was a very important public relations, public health approach to dealing with this massive pandemic. And that came to an end. One of the actions that order did was protected the individuals who were receiving services under the Medicaid program to have their eligibility for Medicaid protected throughout the period that the federal order was in place. So everyone who at that time or came into the Medicaid program during that protected period had continuing coverage. Unfortunately, the protective order did end on March 31st, 2023, and now we're faced with a program that is now called Medicaid Unwind. How do we take people who have been in this protected status for an extended period of time and ensure that they still have the eligibility to receive those benefits on a continuing basis? And it turned into being a rather monumental and overwhelming task, which I think we can comment on a little bit more. When I did meet with our people, they had some concerns that I felt I would like to at least present to you. But I'd also like to say that I also am aware that Medicaid Unwind has left some people without benefits for a suspended period while that eligibility is being redetermined. One of the end results of that has been that some people being served at the mental health center continue to be served, but we've lost revenue in rather substantial amounts, averaging a fair amount, as I indicated in the memo. And the information that I have only comes from the experience I gleaned from the staff at the mental health center. But I'm very sure that the other mental health centers are experiencing many of the same concerns and issues and have some of the same suggestions I'd like to make today to how to move this further along. And there is an organization called the New Hampshire Behavioral Health Association made up of all 10 community mental health centers, and they are currently gathering statewide data on this to I hope, further support the issues that I bring before you today. One of the issues that I'm concerned is over the last 6 months since the protective order ended, the federal order ended, we've lost a substantial amount of revenue, averaging about $250,000 a month. Now, much of that revenue, once the eligibility is redetermined for all those people who are unaffected and have their eligibility currently suspended, will return. And once their eligibility is determined, we're also allowed to retroactively bill back to the Medicaid program to collect for the services that we provided before. However, there is some issue about what will happen with all the people who, for one reason or another, and there are lots of reasons why they may not any longer have the same eligibility that was protected under the federal order, that they will not. And under those people, there is no retroactive payment for the services that will continue to be provided. And so I guess one of the reasons why I brought it up was if there's any way to help some of the mental health centers deal with this lost revenue that they can't now regain the use of, it would be appreciated. In one memo that I thought, and I don't want to go into details about what it works, but there are certain patients, 2/3 of the people we serve in Manchester are considered state eligible, meaning that they're served under a contract that the mental health centers have with the Division of Behavioral Health at the Department of Health and Human Services. And that requires that any individual who has one of the categories of mental illness that are approved for eligibility under this state contract, as long as the experience there falls into one of those 4 state categories, that they're eligible to receive a capitated grant issued through approved by the Division of Behavioral Health and issued through the 3 managed care organizations that administer and dispense Medicaid benefits. And there is another part to that, which is that there is a maintenance of effort memorandum that's out. And each month, we have to look at the capitated rate that's given to each client and collectively look at, did the amount paid out to the mental health centers under this capitated rate fall significantly below, looking at the whole program, did it fall significantly below what was expected, the level of service that they were supposed to retain? And I know this sounds very complicated when I try to explain it in very simple terms, but in fact, sometimes there is a payback. And one of the things that we wondered is there any way that memorandum or maintenance of effort payback and adjustment can be waived during the period of Medicaid unwind as all these people get reestablished with their Medicaid eligibility or find out that they're not going to be any longer Medicaid eligible. I do understand. I did forward the remarks that I gave to you to the director of the Division of Medicaid Services at the Department of Health and Human Services, and he, as he often does, responded very quickly to me about some of the comments that go into more detail than I could possibly go into. I just want you to understand that this report, which is a 1.5 pages long, has to be a gross oversimplification of the whole Medicaid unwind program. I think it summarizes what goes on, but it's a gross oversimplification, and I do hope that some of them, I think some of the details that he outlined to me in his response to my sending it to him would be. I should also say, in terms of my work with Henry Lippman, who is the Director of Medicaid Services at the division, in my experience with him, working with him on several bills where I was a sponsor or co-sponsor that pertained to Medicaid, I've always found him to be a very competent, fair-minded administrator who was ready to listen and always ready to consider any new ideas, and was always a reservoir of information about technical issues that we needed to consider as we made decisions about these issues, and to give us some feet in the ground advice about how things might be handled under difficult circumstances.
And I think when he has his chance to come up later in this meeting today, he'll address some of the concerns that you have, and that'll be very helpful.
And I do understand that it's a possibility that memorandum that maintenance of effort understanding may actually be partially dealt with, as I understood it from his memo, which I was not aware of when I first wrote the memo. However, it would be split, but I think the more we can do to offset that loss of revenue for the people that we can't retroactively bill for would be helped.
Because of time, would you wrap it up, and then we'd like to ask you some questions.
I will. I will try to be as fast as I can. I would also just want to recognize the hard work and effort put forth by all the agencies that are involved, including Mr. Lippman's division at the state level, the local district offices, the community mental health centers, and the 3 managed care organizations that are dispensing those benefits. I do think that, however, that communication is a very vital part of making this whole process work, because the process itself is being added on to the ongoing work of all these agencies. So in addition to all their regular routine efforts, they have this added problem added on to how do they go about resolving it. It is a overwhelming, at times complex, very complicated process that can be frustrating, difficult, and stressful for everybody involved, which can lead to problems in and of itself. But I think it's very important that we look for ways to find all four of the elements to work closely together. I have made the effort to make a few recommendations of how communication might be facilitated to do this so that the four parties can work as closely together as possible to make this a reality. And I think under the leadership of Mr. Lippman and the others, that I'm quite confident myself that it's going to work, but it's going to be a long process. I don't know if I need to go through those 4 steps. I think they're fairly well detailed in that report, but if you have any questions, please feel free to ask.
Would anybody have any questions for the honorable gentleman? Representative Merchant.
Thank you, Mr. Chair. And it's really nice to see you back here in this house, the Honorable Mr. Ken Snow. This speaks a lot to the issue of the mental health therapy that's received by the patient, if you will. It does not talk to, I think, once you go off Medicaid, one of the cornerstones of mental health therapy has been pharmaceutical care, drug therapy. And I'd be glad to understand, or maybe hear from you or someone else, when they go off Medicaid, what impact does it have for them? Because they most likely don't have access to the pharmacy for the drugs they need. So can you speak to that impact as far as looking at pharmaceutical care, what this is having as far as the patient care?
I understand why you're asking that question, and that is one of the biggest challenges when people go off Medicaid. And let's face it, even for people who are in that category called low utilizers, that is people that have moved fairly well into their process of recovery and are doing well, certain maintenance issues have to be maintained. And often that's the maintenance of medication that helps control the various symptoms and issues that arise out of the result of their continuing and persistent mental illness. And that's a real challenge. And I can't go into great detail about how we do it, but we always are looking for other ways to get people insured under some of the other optional pharmaceutical discount programs that are involved. We use free samples that are given out by the drug companies wherever we can to augment it. We also look at, are there any other alternatives that we could use to in addition to what we're going, but it is an enormous challenge that really takes an awful lot of thought and effort on the part of the people providing that care. And I would also say that because we have that kind of contact where we're doing a lot of problem solving around how do I get my medicine, I'm being told I can't, my rent is going up, I have to look for another place to live, can you help me try to locate that? There's a lot of this face-to-face contact that takes place, and of all the partners that are involved, the mental health centers are the ones that have the most face-to-face contact with all these recipients. We're often also in a position to understand some of the issues that could arise that could affect in one way or the other what their eligibility is. And as long as we can take advantage of that face-to-face contact to make sure that information that we may have at our disposal to pass it along would be very useful. And I think I detailed that in my questions.
Representative Edwards.
Thank you, Mr. Chair. It's good seeing you again.
Good to see you again, too.
Honorable Ken Snow. Okay, so you've always been smarter than I am in this area, and so I'm just going to ask you to make sure my summary of what you're saying is accurate. And if it is, a yes is fine, and if it's no, then maybe you could educate me offline. But what I think you're here asking today is that these suggestions on the second page that start with periodic lists and lists provided and all participants, that these are really suggestions for the department, that the department ought to be doing that, and that it sounds like your request or your ask of the legislature is to try to find a way to fill a gap for those people who, in the Medicaid unwind, who haven't been able to find alternative insurance programs that are now left naked in the insurance area, that we find a way to address that gap. And I think, are those kind of the two summary points of what you're asking today?
Yes, I would agree it is. If I could expand upon it just a little bit, I would say that one of the issues is that I think the information is out there. They have attempted to give lists, but there is another group of people, in addition to the four agencies, that are also somewhat frustrated and under a great deal of stress as a result of this, and that is the actual recipients. So sometimes the communication has to be communicated in such a way that everybody's kind of on the same page. And that's what I'm hoping, is that we can find ways to make sure that that actually happens. I think the division does the very best they possibly can in getting that information out as timely a way as they possibly can, but it still becomes a problem, I think, to do. And if we can find any ways to expedite that and see all the parties working more closely together, and you need to understand that all four of these agencies are all frankly understaffed. We all have trouble recruiting an adequate number of people to fulfill all our ordinary routine responsibilities, and to add this monumental task on top of it is a real problem. So they're all understaffed and under-resourced. They try to improve communication, and communication is a time-consuming, often frustrating, and very stressful situation that leaves everybody kind of upset and can lead to finger-pointing at, you don't want to say that things are moving slowly because of something I'm doing, but it's always easier to say what somebody else is doing. And I think communication and appropriate and well understood communication is the best way to offset that. Thank you.
Thank you.
Representative McDonald.
Thank you, Mr. Chairman. I could be wrong about this, and you just mentioned the communication aspect of things. But it was my understanding is unwind was pending as the March 31st deadline was approaching. Notices went out encouraging redetermination and reapplication, and that's why I'm wondering if that was a lack of communication or what contributed to this backlog and delay in redetermination. Can you speak to that?
There's a whole host of reasons, and there's no way I can give you a brief answer to that. The people who had their eligibility, their needs were communicated directly by the division to the individuals. You need to know who the individual we are all dealing with. They're all individuals who know very well that we're obligated to continue to provide services to them, whether or not we have a resource to pay for those services or not. So a lot of times, even though the communication is sent directly to them, they get very stressed. Oh my goodness, I'm going to lose contact with them. So the letter often doesn't really get transported to other people that they're working with face to face. So sometimes it falls apart at that level. I think I can't really find any fault with how they do. If you read some of the letters that go out, they're very fact-based. But for people who are consumers and even people who are approaching this kind of problem with a different perspective, like the practitioners out in the field, sometimes those fact-based letters are a little hard to interpret. So that's why I just stress if we could get all the parties working more closely together and seeing it as a collaborative, as opposed to you do your job and I'll do mine, and eliminate the possibility of that finger pointing that I saw as the biggest dilemma that we have to face. And I don't hold anyone at fault, and for doing it, because I think everybody to some extent is bound to do it when they're under this much stress.
Any other questions?
Sorry, did I answer your question?
Yes. Yeah, thank you.
Okay, thank you, Representative, once, and we hope future.
Yes, I hope so too. I really miss being up here. It was very much doing. I would also like to thank Representative Edwards, who was extremely helpful to me in two of the Medicaid bills that I worked. He spent a lot of time working with us, and I think the kind of communication we had, and I found him a real asset to us in trying to move those forward, and I thank him for that.
We do. The chair recognizes Henry Lippman, Medicaid Director, to give us an unwind update. Oh, pretty colors. Halloween in orange. Yeah.
Good morning. For the record, Henry Lippman, the state's Medicaid director. So I think what I'm about to walk through will sort of complement a little bit what the Honorable Representative Snow presented to you. I hope to share a little bit more perspective of what we have done to protect people. But I guess, first of all, our goal in structuring the unwind was to make sure that anybody who is eligible for Medicaid does not lose it, and those that can't be eligible for Medicaid, that we look to try to help them find other sources of coverage. This effort actually started in July of 2020, and we've been communicating to beneficiaries over a 3-year period before we began, understanding that at some point that continuous coverage was going to end. We started off with a pink letter campaign, which was, to kind of address what the Honorable Representative Snow referred to, some of the communication challenges. We knew that it would be beneficial not to stop our work during the unwind, and if people would voluntarily do their redetermination ahead of time, we'd have more capacity to be responsive to their needs. And close to 30,000 people took advantage of that. About just under 104,000 did not. But it was fairly remarkable to get people to do something when they didn't need to. So we started off with a pink letter campaign and multiple events, some having as many as 300 people on conference calls, sort of briefing them about what was going to happen. We also created incentives in our managed care contract for the MCOs to do outreach that continue to this day in terms of reaching their individuals. And what we actually did is provided lists to the MCOs of the people who were coming up for redetermination, what they were missing to become eligible. We also provided for this roughly 104,000 list to mental health centers, federally qualified health centers, of their people who were in that protected status. And we would update that every month for them, and with the idea that it's really going to take a community effort to try to help some people. So when we finally get to the point where Congress took action to create a definitive end to it, we created a yellow campaign, which was sort of a way to telegraph to individuals as well as people who might be trying to help them that something that is sort of the caution color. Pink, if you will, be a friendly color, yellow be a caution color. Actually, what we had developed there actually became something that was adopted nationally by many states in terms of just a way to, rather than the typical white paper, if you will, very technical things that are required by law in terms of noticing. We also then, in terms of structuring the unwind, did what we called a risk-based approach, which was to the best of our ability, based on information we had, have the individuals that were most likely not to keep coverage be earlier in the unwind, and those that were more at risk to be later in the unwind. And I think maybe, I think that probably no state in the country did more in terms of outreach to individuals. Despite that, there's still individuals who didn't respond. And I think that's, I'll try to get to Representative Snow's recommendations at the end in terms of, I think, what more can be done.
Well, while you're taking a breath, I will repeat that you're a groupie to the Medicaid directors around the country. I know because that came up in one of my fellowships, and somebody said, "Oh, New Hampshire, Henry Lippman?" I said, "You mean the Henry Lippman?" And they said, "Yeah." So continue.
Thank you. Just to kind of give you a snapshot, we're at the third slide, and kind of gives you a high-level view of where we are as of this past Monday. New Hampshire's total enrollment grew to 251,357. That's the number on the top right of that slide. And you can see, if you look to your left, the Granted Advantage program, Medicaid expansion, grew to almost 97,000 individuals at its peak in March. We had typically been running in the low 50,000s. So in terms of looking at where we are today in Granite Advantage, we're almost just under 39,000 less individuals in the program. In terms of that program, that's largely an income-based program, so that if you look at why a lot of people qualified, is the shock of some of the closures or partial closures in the system led to a lot of people being unemployed for a short period of time, and there was an opportunity to gain health coverage where you may have lost it through your employer. And then for just basically 3 years, we didn't go through the normal annual process of checking people's eligibility. We are now required to do so, and that drop in enrollment in that group isn't, I think, totally be unexpected. Some of those individuals could be folks that were in the community mental health center system, but if they're income ineligible, there's not much that we can do directly. What we did do, though, however, is we were the first and only state so far in the country that developed a pilot program with SSIA, which is the agency that oversees the exchanges, and we actually transferred about a little over 20,000, maybe close to 24,000 individuals to the exchange. About half of those would have otherwise gone nowhere under the old system, where so that they had the chance to not only have communication from us, but communication from the New Hampshire navigators and federal government to make them aware of the opportunity to get coverage, federally. We also, in the whole effort, made phone calls to every household, and the ones with the most vulnerable more than once during this effort to alert them. And despite that, there are people who probably may still be eligible that aren't. But one of the things I highlighted in this conversation with former Representative Snow is that New Hampshire adopted one of the federal flexibilities. Ordinarily, someone has 90 days to ask for reconsideration. The federal government offers 120 days for states during this unwind period. We adopted that. So someone may have lost coverage if it's less than 120 days out. They actually can get retroactive coverage to be put on Medicaid. And that's one of the things I think that one of the efforts that can be made at this point is that probably most of the higher risk people are more currently have lost coverage, and there's an opportunity to bring them back on. I think that everybody could redouble their efforts in that regard. The other thing we've done is every month, we started this in June, which is just 2 months into it. When we saw people who had high medical utilization or risk, the Medicaid administrative team made additional phone calls to these people to see whether they knew that they got the paperwork, whether they were in process. We've made almost 2,000 calls of that type, and we've reached over 700 people to speak to them, on top of what we're doing in terms of all the notifications. But I do think that we're right in the period now where it's really important that there's still a lifeboat out there, and we ought to try to be working, as collaboratively we can with both the MCOs and the CMHCs and others.
Just think what you could accomplish if you had an adequate staff in terms of numbers, huh?
Well, I think that everybody's pitched in more, and people worked. I think Representative Edwards asked me a question. Can we sustain the effort through the unwind? A few months ago, and people have stepped up to work extra where we've had vacancies to make sure that we get done what we need to get done. Slide 4 in the deck is really a summary of how we sort of structured who went first in this effort. Slide 5, I think, gets to kind of the concept that I'm trying to suggest is where the opportunity lies today. That what we've seen, and when we report statistics, we're reporting them in the current month for the month that they're due. but what we're also tracking is whether they reopen later. And so there's 3 statistics here. I won't read them all to you, but there are people here that are able to come back on. And when you consider the various categories, the percentage is actually fairly high and worthwhile to go after. In addition, and the next slide, excuse me, which is slide 6, is we, during the process of reaching out and calling people, we also had almost 6% of the individuals, or 7% of the closures actually, were people who told us when we reached out to them, do you still need Medicaid? Told us they didn't. They found other sources of coverage. Some people, there were some reported deaths in the population. But we did this work, I think, again, is unique. Other states have reached out to me, Missouri, I think it is, most recently, about how we did this. And it was a combined effort of the department and the MCOs in that regard. Slide 7 is kind of what's our statistics that are reported federally and what we keep separately. Orient you a little bit to this chart. I think there are really 3 sections. The column that's titled grand total is what are the public-facing statistics that CMS will ultimately report on the month. We divided it between what we call the protected population and the non-protected population. As I mentioned before, the protected population was about 104, just under 104,000 people. The balance are what we call non-protected, meaning that they were never subject to that COVID situation in terms of having continuous coverage. They're going through an annual process and renewal process. And the slide on that I have up first here on slide 7 is the month of September. What we've seen over time is that, based on our structuring of the unwind, that as we expected to go further into it, the people who we were trying to protect the most were more likely to keep coverage. And that's exactly what we're seeing in the statistics in both the protected and the non-protected categories. If you look at sort of the flesh tone part there, that for the month of September, that 79% overall retained coverage, and that's broken down in between the protected group, the people that had the COVID protections, and the non-protected group, which are people coming through their routine. That next section is the area where the non-procedural, the procedural folks are the ones that were that special pilot, which would have otherwise dead lettered, meaning nothing would have happened to them. And so those have been referred to the federal government for further work and work by our local navigators. And then an additional level of detail that we provide down the bottom, which isn't federally disclosed, but we've been looking at, is what were the reasons for the closures? Was it income? Was it that they failed to redetermine? That's the category there that failed to redetermine one that, despite all the efforts, that there are people who haven't acted at this point to complete their redetermination. The next slide down, 8, is sort of the cumulative effort. And here again, I think that earlier on in the campaign, if you will, individuals lost coverage were more due to income, that those were the people that we had a good indication were over income based on information we had. Okay, move it along. Then the next slide is what we've done to make it easier on people in terms of when we have enough information to determine their eligibility without them submitting additional information. We've made adjustments in policy, both in what CMS allows and what basically how we structured the population, which has led to the more recent months where the most vulnerable people are, that we've been more often been able to do a review without them even requiring their paperwork. In the upcoming month of November, it will be 74% of the population will be renewed without having to go through the torturous process of completing the application. Slide 10 is just the kind of where we're at. We're about 97% through the unwind as of today. We're really slowing down a lot now because we got and extended the period all the way up to May it's small numbers, but it's the really most vulnerable people, people that are home and community-based and nursing homes and such, that we really see that they need more help than some of the people earlier. And then the last slide I have is just a summary of sort of our call campaign, that extra effort we make when we see each month the people that have medical conditions showing up in claims that suggest that they need some additional outreach. So I guess to make a longer story short, we're certainly open to working with the community mental health centers further. I think it's not something the department can control. It's something that everybody's got to make their best contribution to it. The MCOs, when people come in, if they have a authorized rep relationship with them, they can do a lot to see what's going on. The MCOs, even one of the MCOs has developed a lookup file where people can check their members. We're in the process now with regular renewals. It's a dynamic changing group of population, so we can't produce the same kind of reports we could when it was a static population.
Will you take questions, please?
Sure. And the last thing on the maintenance of effort, if I could, is that there is in our contract currently with the MCOs a 50% disregard if they don't make the number of visits and such that they should under their contracts, which we've had in place for quite a bit of this contract. And we're evolving the contract in the re-procurement to a very different system that will be helpful to the community mental health centers.
Chair recognizes Representative Edwards.
Thank you, Mr. Chair. First, Mr. Lippman, I just want to take the chance to congratulate you and your team again on outstanding implementation of the new Medicaid rates, reimbursement rates. It turned out to be a far more complex project than what we had assumed in the legislature, and you guys brought in your actuaries and did all the community outreach, and it was just, it's the only thing I've ever gotten somebody from the community to call me and tell me how great it was. So normally people call me to complain, but that was great. A small thing, as I look at page, and you don't have to address this, but just to let you know,
Sure.
As I'm looking at page 7 under total closure by reasons, and I look at failed to redetermine, and then I look at the graph presentation of that on slide 10, bottom left hand. It looks like the data is different and the graph doesn't present as I would have expected. So I just would say if this is public facing, you may want to have somebody just double check that.
Yeah, I'm confident in the numbers. It's just it's a different kind of look. That the stuff that's in the table is sort of a what's done, and what you see in the bar chart is sort of forward looking. We're looking at October and November.
Okay, so that's a future state.
Yep.
Okay, and then my favorite question to you, now that we're sort of so far along in terms of having the Medicaid contract renewed, are you confident that we're going to have at least 3 MCOs at the end of the day? And I know you're limited to what you can say because it's proprietary, but if you could just kind of indicate whether you think we're at risk.
Well, I think one of the questions you've asked me in the past is, what is going to be the enrollment figure that, because you need about 60,000 per MCO to make it worth their while to be in the market in terms of being able to compete. I think that, right now we're at just a little bit above where we were Last time we went out for procurement, there are several policies that are in HB2 that we're in the process of implementing, which will have some effect of marginally increasing enrollment. That was the postpartum coverage that went into effect 10/1. Effective January 1 is for the legally residing pregnant women and children, but probably the larger one is a federal requirement that all states have to adopt, which is children have to have 18 and under have to have 12 months of continuous coverage. And so that I think will have an effect of making the market just a little bit more attractive. I do think that we'll have 3 MCOs through, we have all through amendment, what I'll call contract number 2, the 5-year period that ends this August. And I suspect that we'll continue to have.
Thank you. Again, great work on the Medicaid reimbursement rate adjustments. Thank you.
Thank you.
And thank you, Mr. Lippman. Look forward to your occasional updates.
Happy to do so. And I think Dr. Finney's here to do a little bit on checkup on our dental program.
Something we will get our teeth into.
Or we'll be down in the mouth.
Pretty bad.
We went 10 minutes without a dad joke. What do you mean? Okay, yes, hi.
Good morning. Dr. Sarah Finney, Medicaid Dental Director. Thank you very much for allowing me to have some time this morning to bring you up to date on the adult dental benefit. I believe you have a handout. I want to start off with really the most important thing, and that is how many of our members are getting services, because that's what this whole thing is really all about. And I'm happy to say that between April 1st, which was our implementation date, and now we have had over 8,000 unique members served through the dental program. And the vast majority of those have had more than one appointment, but this is one of the things that we track to really see how things are going in these early days of the program.
So Dr. Finney, just so I understand the graph, this is each month. This is not cumulative?
The graph is each month.
Okay,
and
thank you.
8,000 is the cumulative number of unique patients overall. You'll see that there's a steady increase in the number of members as well as claims, with a slight dip in July, which is very normal. I've seen that with my experience in the children's benefit. Providers and members alike are not at work and at home. And that's to be expected. We do have a little bit of a claims lag, usually 2 to 3 months. So September, when we pulled these numbers, we know that we still probably don't have all of the September claims. So when I report to you again, that will show the correct amount. And I do believe that we are seeing steady growth month over month. And the preliminary numbers that I have for October show that to be true. I think it's important to point out at this point that both Northeast Delta and DentaQuest are engaging with providers to make sure that they understand how the claims process is working in this program, and they are training providers and their office staff so that claims processing goes through expeditiously. And they're also reaching out to support members as an effort in recruitment to show that they really are dedicated to making sure that there is minimal administrative burden for our providers. And then one little piece of information that I wanted to share, because I think it is a concern that we all had going into this. Out of the 39 oral surgeons that are practicing in New Hampshire, 20 are enrolled in this benefit. And that speaks to the recruitment efforts that have gone on, and I'm very happy with that. And recruiting is still going on. That has not stopped. It will not stop, and is a very important part of the whole program. That leads nicely into the next page, which is the actual network dashboard. So we have 142 unique members at 103 unique locations. As I said, 20 of those are oral surgeons. and that is at 20 different locations. We also are taking advantage of some providers along our borders who do have experience. In the past, they have treated our Medicaid adults when they just had the emergency benefit. And, we have added them to the network because that's an important piece for some of our residents who are at the border, and that may actually be the most convenient location for them. And we also do provide a breakdown. There are 10 providers who are Take 5, which means that they've agreed to take on 5 members, see how it goes. And, the idea is that with the support that DentaQuest is providing for administration, that will lead to them actually seeing more members. 57 are off directory. And 41 providers are seeing their existing patients, which means they had adults that were in their practices who were Medicaid eligible, and they are maintaining them in the practice and treating them now under the new benefit. And then currently 11 are treating special needs patients only. To the far right is the breakdown by county. And I will say that recruitment efforts are driven by our priority area needs. So as new dentists enroll and drop into that breakdown, it will change the emphasis on what areas are more active in recruitment. So there's a lot of movement. It's all positive movement, and we are adjusting as we go. I do want you to know that our frequency of meetings with Northeast Delta and DentaQuest has not slowed down from our implementation practice. I am not exaggerating when I tell you I have at least one meeting a day that involves something to do with the adult program, because we are focused on making sure that it is functioning the way that it was meant to. The next page goes into our mobile dental clinics, which is another critical piece of the network. We realize that there are certain areas of the state where we may never have the bricks and mortar dental offices to really take care of our members. And so we're using mobile services to fit into the network so that we're getting services to those areas. This schedule changes. This schedule looks slightly different than it did last week, and part of that was based on demand. I'm happy to say that this weekend, Saturday and Sunday, the mobile van will be in Laconia at Health First, and they have a very robust schedule. On Saturday, there will be 2 dentists working there, and they have 20 patients scheduled, and on Sunday, there will be 1 dentist there, and they have 12 patients scheduled. And that's what we're aiming for. When the van goes out to a site, we want to make sure that chairs are filled and that time is being used efficiently to best serve our members in those areas. And the mobile services are not one and done. They are definitely planned with a certain frequency. We want to make sure that those services are available on an ongoing basis. And so you'll see as the schedule develops that we do go back to the same locations month after month. And that is to make sure that not only are urgent needs taken care of, but those members are getting ongoing services that they need. And then the last part of the program that I think is also very important is stakeholder engagement with various organizations and agencies across the state. Northeast Delta and DentaQuest have taken very seriously the importance of them being involved with outside organizations to really get at what our members' needs are, how do we best serve them, how do we support the dental providers in the network so that they can serve members effectively. And to that end, there are items that specify really for dentists, including oral surgeons. And as I mentioned earlier, there is one-on-one recruitment outreach still ongoing across the state. The team from DentaQuest and Delta is involved in different conferences and educational opportunities that are going on regarding oral health across the state. Probably one of the most helpful things that they have done, the team goes out to the New Hampshire Dental Society component meetings. Every fall, the latest president of the Dental Society goes out and meets at each of the 9 components. And that is a perfect opportunity to meet dentists in a small setting. It allows for conversations, and I would say that that has been an important part of recruitment, is getting the word out, not only from the side of Northeast Delta and DentaQuest, but also to speak to dentists that are already providers and can speak to how things are going, and hopefully encourage other dentists to enroll as well. And the team is also involved with the New Hampshire Oral Health Coalition and all of the things that they are working on. So they're really trying to connect at many different levels. The team also is meeting with nursing facilities. We have bi-monthly meetings with the Nursing Home Association, which allows for a back and forth conversation. We get real-time information about how things are working, possibly where we need to make some adjustments, and making sure that we understand the needs of our residents who are in nursing facilities, because their needs are definitely going to be different than a lot of our other members. And that conversation includes working with the transportation vendor, because we know that that's an important piece of the benefit there. And then lastly, the special needs population is one that we're really trying to make sure that we have not only the providers available that feel comfortable and ready to treat those members, but also to give them support, training, continuing education that will allow them to continue to do so. And again, also to introduce other dentists who may not have considered that they were ready or able to treat that population. ABLE New Hampshire started up an oral health task force within the last several months, and our team attends those meetings. That has been a wonderful place to really talk with individuals that have special needs and learn about what their past experiences have been attending dental appointments, and what are the things that really make or break that relationship for them. And we can learn a lot from that group. We also work with area agencies. We're working with the UNH Institute on Disability. They actually have a training module for medical professionals to work with special needs individuals. They're very excited about the adult benefit, and they would like to actually try to do a second version of that training module that is very specific for dentists. And so we're working with them to develop that. That will be something that can be done online at the convenience of providers, and is meant to really be supportive and to lead to an increased enrollment with these dentists. And then we're in the early stages of discussion with an organization called Special Smiles, which actually originates out of New Jersey. They have a whole program that they're very versed in treating special needs individuals who need anesthesia. And so again, it's just another organization that can help us to learn what it is that we need to provide, what supports are out there, so we're not recreating the wheel here in New Hampshire. If there are programs that we can gain information from, we're trying to do that. And I will take any questions.
Any questions, Representative Merchant?
Thank you, Mr. Chair. Thank you, Dr. Vindy, for taking my question. One of the things talked about before is the issue of no-shows and what impact it will have on providers. And my understanding is that a no-show is not being compensated by the program. So are we tracking or somehow tracking no-shows to ensure that we're not having a situation where the providers are not getting compensated because once they book the time, they can't rebook it?
Very good question. And yes, we are addressing that. There are codes, there are dental codes that track that. And what DentaQuest is doing is monitoring when those codes come in, and they go to see who the member is that's involved. And there is outreach directly to the member to get at what the reason is that they were unable to make their appointment. And this plays in with why we felt it was so important to include care management in this plan and also the transportation.
Mr. Chair. Follow.
Follow up?
Thank you, Chair. Is it possible to get a chart of how that's going over time? Is it increasing, decreasing, remaining stable? Is there a way to get some sort of documentation data?
I can certainly get that information.
If I could just tag on to that comment.
You may tag.
That was one of the questions I was going to ask. But if you're going to provide us that graph, it might be useful to be able, if you're able to benchmark against like the commercial or the private pay no-show rate, because I think the extent to which our program has a higher or lower no-show rate than private pay, that is a significant red flag if we've got a problem to address. So
Okay.
and then
Follow up?
I want to tell you that the way you're managing this program is far more complex and is greater than what Representative Shapiro and I imagined when we first started, bouncing this around. So I want to thank you for the maturity and the development of this program. It's great. I'm looking at slide 3 under the county breakdown on the network dashboard.
Yes.
And there's a free-floating arrow there. I don't know if that arrow is meant to indicate that Belknap is a concern.
No.
As I look at it, it looks to me like Sullivan is a concern.
My apologies. That arrow, it was meant to connect the total unique providers and locations. Like, look over here, this is the county breakdown, and it should not have been aimed at, it should have been aimed at.
Okay. No sweat. But so then my real question there is, under this management by exception principle, if you think Sullivan County, for example, is the county that we should be focused on and worried about, and everyone else is okay, it would be good to know where your big red flags are in the state.
I would say that Sullivan right now is probably the biggest concern. And we have a tremendous amount of outreach going on to determine, where are the folks really residing? How far are they having to go? Because there are several 2 providers there. So that is an area of concern. And that's why that has now been added into the schedule for the mobile services, because we realize we need to do something right now while we're continuing to recruit more providers.
Thank you, Dr.
Representative Weber.
Thank you, and my apologies for coming in late. I just had one quick question on the on the county breakdown. I see that Cheshire County is in there twice, once with 5 and once with 3, and I'm wondering why Cheshire is there twice, one with 5 and one with 3. And I assumed maybe it meant that people were going out of state to Vermont, but I see that that's broken out separately.
I will ask this was provided by DentaQuest. I will ask them about that, and my apologies for not catching it.
And it's just my personal curiosity because that's my county. Thank you.
Okay. I will get an answer for you.
Before you leave, I made the developmentally disabled community one of my interests when I first ran for the House 7.5 years ago. And I just want to say that the feedback I get from them appreciates your visits. They are very happy for that. So thank you. And thank you both.
All right. Thank you.
Lest I forget at the end, our next meeting, because the 4th Friday is the day after Thanksgiving and we're all asleep from tryptophan. Our next meeting will be on November the 17th, the third Friday. And when we go to third Friday, that's 1 p.m., not in the morning, because of some other groups that meet in the morning. Thank you.
And Mr. Chair,
Yes.
looking at the calendar again in December, it looks like it's going to be the Friday.
I am about to say that there is some question as to whether we should meet in December. If we did, it would be the 15th at 1 p.m. And given the number of items that need to be presented to us, I would be in favor of meeting in December. And if you wished privately to email me and let me know what you think, if I have two lists and one says 5 and the other says 3, I will conclude that's 8, like Cheshire County.
Mr. Chair?
Yes.
I just want to let you know, if my ankle is holding up and improving, I will be out of state on the 17th.
Okay. Well, we promise not to have too much fun then. Okay. Next, annual report on the implementation of New Hampshire's 10-year mental health plan. Julianne Carbon, Deputy Director, Division for Behavioral Health. Rebecca Ross, Director, Bureau for Children's Behavioral Health, both at the DHHS. Welcome. And we have a nice, juicy report from you.
Yes, we have packets on the tables for the annual report. And as you can see so good morning. My name is Julianne Carbon, the Deputy Director for the Division for Behavioral Health, joined by my colleague Rebecca Ross, the Director for the Bureau for Children's Behavioral Health.
What?
Speak closer.
Closer.
Thank you.
Welcome. Thank you.
So it's a pleasure to have an opportunity to speak with you this morning regarding the 10-year mental health plan. As you can see from the report, a lot of progress has been made since the report was published in 2019. This morning, we just want to go through a few of the highlights in the report from the last year. So we'll start in the area in terms of the goal for expanded coordination of our continuum of care. And we really want to highlight the progress that's been made through the state's New Hampshire Rapid Response Crisis System. As you're all aware, we've created a centralized crisis contact center that within the last year and a half, it's responded to over 40,000 calls and deployed mobile crisis response teams over 9,000 times to respond to children, youth, families, and adults in the community in their greatest time of need. Since June of 2022, we've also expanded critical time intervention to be a statewide service, and that program is an evidence-based practice that supports adults through transitions of care. And for many of the adults served through this program, they're hitting the mental health system or experiencing the mental health system for the first time. And this program really helps to provide targeted, concentrated support to help that transition from the hospital, from a designated receiving facility, back into the community, to be better coordinated and more integrated to help their success in the community. Another area we want to highlight is in the area of prevention and early intervention. So I'll turn that over to Rebecca.
Thank you, Julianne. Good morning. We did want to highlight that we have been able to expand our care management entity services through the early childhood wraparound services, similar to Fast Forward, but this service focuses on the birth to 5 population as well as the caregiver needs. And while we launched it with our first services last July, this July 1st, we were able to receive Medicaid approval for it to be a covered benefit through Medicaid, and really innovative in that it is based on needs and caregiver needs in order to prevent or address ACEs before we're deeper in the system. And we're the first state to have had CMS approval for that type of Medicaid benefit that is very much prevention focused on early childhood, so that 10 years from now, we're not having the same conversations about the deeper end of the system.
And lastly, we wanted to recognize the work taking place to address workforce challenges. Just recognizing the need to proactively build our workforce capacity, the department has been working on several initiatives to create new career pathways into the mental health system. So, for example, we worked in partnership with our community mental health centers and New England College to create a new bachelor level cooperative learning program where students are able to enroll in the class as well as work for the community mental health center under supervision and provide services to their local community. We've also been working in partnership with the college system to create new certification programs. One is for our peer certified specialists, and the second is for specialty crisis responder certification program. And both of those certification programs we anticipate rolling out through the community college network in early 2024. So, in addition to new career pathways, new career programs, a lot of effort and funding has been invested in training for our current workforce, both to increase their competencies in specialized services in an effort to cross-train staff, as well as to have a focus on improving job satisfaction and retention within our community mental health centers. So that's a very high-level overview. I mean, as you can see from the report, a lot of progress has been made. And as we look forward to 2024, the department continues to be focused on these priorities and goals within the 10-year mental health plan that are outlined in the cover letter. So we're open to questions as you have them.
Anyone? Representative Edwards, we have to have a question.
Because I can't help myself.
I know.
Okay, so this is all a very positive thing you've told us, right? And today's theme for me is management by exception. So is there something going on that we should know about that you're just a little concerned about in terms of the development of the 10-year plan? Or, I mean, you're very positive. There's got to be something broken somewhere.
That's why, we have the plan before us. I think what's positive is that we have a clear strategy. The challenges are absolutely embedded in this cover letter in terms of this is why we are focusing on these areas. There are concerns around access to care that really is rooted in the availability of workforce. Those are the significant challenges that we're seeing in our system, is being able to find and retain enough workers to provide the services that have been invested in and stood up around the state. For example, you've heard us say before that the mobile crisis system is staffed at about 50% capacity, and other programs are seeing similar staffing patterns.
And thank you for drawing my attention back.
Thank you for your presentation.
Thank you.
The chair recognizes Wendy Altman, Bureau Chief, Bureau of Elderly and Adult Services, on a review of the draft plan public awareness campaign on brain health, Alzheimer's disease, and related dementias. And we are only 4 minutes running late due to, again, Attorney Williams's wonderful timeline.
Is the handout something we already have?
Do we have the handout? I don't think it's that. I think that expands on this, but maybe not. Thank you. Wow, we were esteemed. That is good to know.
Good morning.
Good morning.
For the record, my name is Wendy Altman, and I am the Bureau Chief for the Bureau of Elderly and Adult Services at DHHS. I am here today to talk about the plan that the department has for engaging in a public awareness campaign for Alzheimer's disease, and related dementias. As a result of House Bill 2, the department was mandated to put forward a plan for a public awareness campaign and a process for procuring a vendor in order to carry out that plan. So in front of you, I have an executive summary providing an overview of why we are doing this and our intent, as well as a high-level timeline, which includes some of the activities that we are planning over the course of the next biennium. And on the other side of the plan, we have provided a draft of several of the deliverables that will be required as part of the procurement for a vendor for this public awareness campaign, as well as the reporting and monitoring outcomes, which as part of the legislation described that our plan and our public awareness campaign needed to include. And I'll just provide a high-level overview of the timeline and activities and talk a little bit about those deliverables and then be able to take any questions. So I'm happy to say after today, we've completed the first set of activities as part of this plan. In July, we began meeting and working with our partners with the Alzheimer's Association, as well as the New Hampshire Commission on Aging on implementing an outline and a framework for our process and our plan. And we have been working internally at the department to develop the RFP and work with finance in order to make sure that we've put our package together in order to put out a procurement for this vendor. And we are working with the Alzheimer's Association and the New Hampshire Commission on Aging on the development of the plan that you see in front of you, and we will continue to work with them during the procurement process. Starting in November, we will be following up with the contracts unit, or basically after today, we'll be working with them in order to get the procurement released, and then we will go through that procurement process and then begin working with a vendor once we're able to get the contract approved. Starting in February, we hope to be working with that vendor and having kickoff meetings, coordinating with those named partners as part of the legislation and others within the department and as part of our stakeholder and provider partners in order to be able to deliver the work and have a campaign launch. And then be monitoring and overseeing the activity, as well as beginning to formulate what we will be providing as a report in terms of our outcomes and the related deliverables and perhaps even next steps. And I'd like to say also that we're monitoring this work and activity as part of our state plan on aging. And we will be including our goals and objectives related to our state plan in terms of age-friendly language and working with our stakeholders and partners in order to make sure that the work that we're doing intersects with this campaign and can benefit from it. In terms of deliverables, we are hoping to develop a comprehensive multi-model marketing campaign in terms of public awareness related to brain health and Alzheimer's disease. We also hope to develop and utilize differentiated campaigns that look at other target audiences and expand our statewide effort. We will collaborate with community partners and leaders in order to extend the reach of the messaging that we hope to accomplish. And intend to look at different models of being able to look at the reach that we have, whether that's through multimedia platforms as well as accessible platforms for individuals. And another important part of this plan is the reporting and monitoring. And we want to be able to ensure that we are monitoring our vendor and working with them. So we will be doing quarterly work plan updates and deliverables and monitoring the budget and learning from this, as well as looking at the number of individuals who are going to be reached through these paid media efforts, and our stakeholder community feedback and fiscal reports. We will be partnering with those, the Alzheimer's Association and the New Hampshire Commission on Aging to give them regular updates. I am currently the Department of Health and Human Services representative to the New Hampshire Commission on Aging, so I will be actively involved in making sure the rest of the commission members are aware of the work that we're doing, and we can engage with them to answer any questions that they have throughout the process. We do intend to put together a final status report that we will come back to the Oversight Committee to present and be able to answer questions. And certainly if there are any recommendations or outcomes to this that may lead to future activity or requests, we will involve the Alzheimer's Association and the New Hampshire Commission on Aging as a result of that, and we'll make sure that it's compatible or comports with their goals and objectives as individual groups as well.
Any questions? Representative Weber.
Thank you. I didn't see that coming. I thought you were lateraling in the other direction, but thank you for taking my question. I'd love to hear a little more specifically how the outreach is going to happen. Are we talking advertisements? Are we talking social media? Are we talking television? I just, I gather it's multimodal. I gather that it's operating in a number of different ways, but I just want to know specifically what you're thinking about. And I realize that will depend to some extent on what you and a contractor come up with in both the contracting process and then in developing the campaign. But what do you have in your thoughts as to the precise methods of communication?
Thank you for the question. We do expect to outline a high-level overview of the types of outreach and media public awareness campaign activities that we would like to see with the funding that we have appropriated for this project. As part of the request for proposal, we will be asking the vendor to propose a budget as well as in terms of being able to meet the goals of statewide activity and reaching all of the different audiences that we have, coming up with a plan that will include both, I envision, TV, radio, social media, as well as paper and other accessible modes of doing outreach. We will be asking the vendor to do some focus groups and engaging the public in terms of what they would like to see or how it will penetrate the population that we want to serve through this public awareness campaign. So I anticipate there may be things that they will propose that we don't know yet. There may be strategies because and we're working with our public information office too. So we will be partnering with the vendor with our public information to do this.
Representative Merchant.
Thank you, Mr. Chair, and thank you for taking my question. Thank you for what you're doing. It's important work. There's also a subcommittee of this committee dealing with Alzheimer's. Can you explain to the committee how that subcommittee is going to intersect with the work here that you're doing? Where is that intersection going to occur, and what is going to become of it?
Thank you for that question. In my position, I've been newly nominated to sit on that subcommittee, and I am awaiting information in regards to scheduling of those subcommittee meetings, and will be, as part of that process, I imagine that we will be discussing this plan and giving regular updates to that subcommittee as well.
Thank you.
Representative Edwards.
Thank you, Mr. Chair, and thank you for this report, Ms. Altman. Mostly for the committee's purpose, and if I misstate this, correct me. This program was initially identified and put into legislation, and the initial draft of the legislation wasn't particularly comprehensive in terms of the extent of what we would expect. And I think we went back and we worked it with lobbyists and probably back with Ms. Altman. And I really appreciate the level of specificity. This is about the right level for the legislature to know that you are spending the $500,000 well. Because that was the initial concern. The legislation was so ambiguous, we didn't know what we were going to get for $500,000. And so this is reassuring. Thank you for that work. I'd also like to just point out mostly for the executive, for the committee here, that public health has the mission of providing public-facing education. The topic of Alzheimer's and dementia has been on the radar for many, many years, and because public health just was never able to get to it, we thought this special effort was appropriate. And as I understand it, when we get these deliverables and programmatics set up, the responsibility to sustain it will shift from you over to public health. Is that true? That's what I understood the plan to be.
We haven't discussed sustainability of any ongoing outreach or public awareness, but I know from my perspective, we partner very closely with the Division of Public Health and Population Health. We're engaging in activities related to age-friendly public health systems and brain health. And we're coordinating with them to ensure that we're collecting data and information related to Alzheimer's disease and related dementias in the state through some of their data collection purposes. So we've set the stage really for future engagement and sustainability of this kind of work.
Follow up.
So this is actually from Ms. Henn. This is just a comment that one of the concerns when we looked at the legislation around this was potential redundancy. And it's great to go ahead and do a new program in the department that it's supposed to be in for the subject matter expertise. But I hate to have us come back in 2 or 3 budgets from now and see that we've got redundant public awareness organizations. So if you all could just pay attention to what's the right degree of redundancy and what's the right degree of alignment, that would be great.
Good. Thank you. And thank you.
Thank you very much.
As we close, next meeting will be November 17th at 1 p.m. We've got some fun things scheduled. Update on protocols for complaints and investigations with the Board of Medicine. You may remember former Representative Soloway and I basically co-chaired a subcommittee of this group to look into that October of a year ago. Also, the DD and ABD waitlist quarterly report will be up next month. Also, report regarding the use of restraint and different modes of transportation of patients to New Hampshire Hospital and designated receiving facilities. That's something that we really want to be very cognizant of. It's an important issue. There's other things as well, but those are just three highlights. Those of you who know of a subcommittee in law that has been dormant and you want to reactivate it, get in touch with me. I know there's a few people interested that we would start a new subcommittee. Again, let me see some developments on that. And possibly we will have a meeting on the 15th of December at 1 p.m. Let me know. And since we started 2 minutes late, the chair declares we ended 1 minute early. Thank you.
Mr. Chair, did you need a motion to adjourn? Because I still had one more comment for you.
No, we don't need a motion to adjourn.
Okay. We've got CISNY here and an area agency and the BDS. I don't know if any of them had wanted to say anything.
We're okay on that, Representative. Thank you. We'll hear them next month.
All right.
Mr. Chair?
Yes.
As far as the next meeting, there was some discussion by Representative Weber to either go a little longer or holding additional meetings in a month. May I suggest to the chair and to the rest of the committee that we try out in November 15th to go a half hour longer?
I'm sure that Attorney Williams will find a few things to add to the agenda. Thank you.
Thank you.
Let's try that, see how it works. But hold December 15th.